last speaker for the early part of the afternoon session. Dr. Agaram, Narasimhan Agaram, is bone and soft tissue division with me. He came in 2011, did his search path and cytology fellowship at the Memorial way back, okay, just like Hikmat. Narsi is also, so he does cytology, bone and soft tissue. He's also a vice chair for the QA, so he wears many hats. He works with Christina Antonescu a lot on the translocation-associated sarcomas.
Thanks, Mira. So my case that I'm presenting today is that of a 67-year-old man with portal hypertension due to cirrhosis, now with a 4-centimeter esophageal, paraesophageal mass. By the way, this is my only connection to liver today. So this was a consult case which the outside pathologist submitted. And as part of their letter, they said that the patient had had an initial biopsy of this esophageal, paraesophageal mass, but it was very limited tissue. They could do only a few stains, and based on the morphology, they did a few stains. It was synaptophysin positive, keratin was negative, and a low Ki67. And they were considering the possibility of a neuroendocrine tumor, something along the lines of paraganglioma. In their letter, they also said that the patient's granddaughter had a mediastinal tumor removed 15 years ago. They were unsure of the details, but there was some mention of hypertension in the young lady. But however, our patient did not have any systemic hypertension or any elevated catecholamines. So they sent us the resection material. So here's the tumor, G junction tumor, as we see here. And the tumor is sort of mainly located in the gastric, in the wall here, G junction wall, a lobulated tumor. In focal areas, it sort of ulcerates the mucosa. Otherwise, it sort of mostly involves the wall. Here's the muscularis propria, and also goes down to the serosal aspect. And as we can see, it's a very lobular tumor. Some areas had this very glassy pink, almost osteoid-like material at the periphery focally in multifocal areas. Other areas focally showed infarct-like necrosis with some dystrophic calcification, ossification. Going to the cellular areas, most of the tumor had this very monotonous round cell look, which on higher power, again, shows these round cells, a little bit of cytoplasm, but very uniform, monotonous round cells. There were also other areas with very distinct nesting pattern, as we see here. Again, going higher, very typical nesting pattern, or sort of trabecular to nesting pattern. And some areas in these nested areas also showed some cytologic atypia with these very large nuclei. There were also other areas on the slide with this very primitive spindle cell morphology, as we see here, showing these spindle cells and fascicles. And again, not much cytoplasm, but very primitive appearing spindle cells. So there were focally, the tumor was mitotically active. We counted up to 8 per 10 high power fields in terms of mitoses, at most. And very focally at the periphery, there were some areas with this focal vascular, increased vascular pattern, like here. Similar cells, though, with this vascular pattern. So based on the fact that the biopsy was synaptophysin positive and our tumor had this morphology, again, the main thought was, is it some sort of a neuroendocrine neoplasm? But then given the growth pattern and the spindle cell areas, we put in a bunch of mesenchymal neoplasms in the differential. Just going over some of these differentials, of course, we know about neuroendocrine tumors. Epithelioid GIST, we know, can show these very epithelioid cells in sheets. However, the cells look considerably bigger. They have a lot more cytoplasm than in our case. Usually positive for c-KIT dog1 most of the time, and are negative for most of the other markers. Epithelioid Leiomyosarcoma can also show a very distinctive epithelioid morphology, but cells are much larger than in our case, have a very distinct cell borders, and almost always a strongly positive or SMA and Desmond, and usually synaptophysin and c-KIT dog1 negative. GI clear cell sarcoma, another mesenchymal tumor of the which can show a relatively primitive appearing small bore round cell morphology. But what we typically see in this tumor is presence of these giant cells scattered throughout, and this tumor is usually strongly S100 positive. This tumor, we can see tumor cells in either sheaths or nests or even a pseudopapillary pattern. They are strongly S100 positive, but unlike the clear cell sarcomas of the soft tissue, the melanocytic markers are much less consistent. And we know that these have EWSR1 related gene fusions. Another new relatively newer tumor in the gastric realm is the gastroblastoma, which is a biphasic tumor which can have an epithelioid as well as a spindle cell morphology in the same tumor. Like in our case had an epithelioid and spindle cell morphology. However, in this tumor, pancytokeratin is positive in the epithelioid cells, but the spindle cells are only vimentin positive and are usually don't show any positivity for other markers. And this tumor has been associated with the MALAT1 or GLI1 gene fusion. One other thought we had, given that osteoid-like area is not from a primary tumor setting, but probably in a metastatic realm, was ossifying fibromyxoid tumor, which can also show a similar pattern of round cells with this distinctive osteoid-like material deposition. There have been no visceral locations described in this tumor so far. They only occur in the soft tissues, but they may or may not be positive for S100. They don't have a specific immunoprofile, and they're usually associated with PHF1 gene associated fusions. So how did our tumor stain? As we expect, this was strongly positive for synaptophysin, as the outside pathologist had mentioned in the letter. Smooth muscle actin was diffusely positive in this case. Desmond was negative. Here the muscularis propria, straining internal control. CD117, dog1 was negative. CD34 was patchy. Most areas were negative, but some areas had this positivity. They had done a TLE1, and this was diffusely positive. Not sure why they did this, but this was diffusely positive. BCL2 was also positive. And INI1, which was performed, was retained. Ki67 was relatively variable. Some areas showed an increased mitotic, increased proliferative activity, like here, but other areas relatively less, and some of the areas which are more vascular almost did not show any proliferative activity. So this was the immunoprofile. Again, slightly conflicting immunoprofile with TLE1, synaptophysin, a patchy CD34, strong SMA positivity. And then we had done other markers for HMB45, STAT6, which ruled out a solitary fibrous tumor, a pecoma, and of course this was not really a GIST with the negativity for c-KIT and dog1. And cytokeratin was negative, again, thereby pretty much excluding a gastroblastoma. And this was seen at the GI pathology by all the GI pathologists, and they felt this was not a neuroendocrine tumor. So we could pretty much exclude a lot of our differential. And given some of the mesenchymal tumors that we had some FISH probes for, we did some FISH on this case. And this tumor was rearranged for the microRNA 143 and Notch2 genes, but there was no rearrangement of the PHF1 gene. What does this mean? This means that this is a malignant Glomus tumor. So just give you a brief update on what's happening in the world of Glomus tumors. So what is a Glomus tumor? Glomus tumor is a mesenchymal neoplasm composed of cells resembling the perivascular modified smooth muscle cells, or the pericytes, which are typically cells we can't see normally around each vessel. And so it's a pericytic neoplasm. And the other tumors in the pericytic family that we consider are myopericytomas and angioleiomyomas. Again, very varying levels of smooth muscle differentiation between these three tumors. But they all stain for SMA strongly. However, the level of smooth muscle differentiation is different. So glomus tumors are rare, less than 2% of soft tissue tumors. They can be multiple in the same patient. They can occur at any age, but most are diagnosed in young adults. There is typically no gender predilection, except that the subungual lesions are supposedly more common in women. They can be seen at any site, but a vast majority occur in the distal extremities, particularly in subungual locations in the nail bed, the hand, wrist, and foot. And they can also occur in deep soft tissue, and among the visceral locations, GI, GU, bone, lung, and mediastinum, pretty much anywhere glomus tumors can occur. But they unusually occur, large numbers of them occur in the gastric location, in the stomach. So from the AFIP, this is a paper from AFIP, and they looked at 32 of their cases of glomus tumors involving the gastrointestinal tract, and 31 of the 32 cases were in the stomach. And there are also multiple other papers of multiple cases from gastric locations. So stomach appears to be one of the more common locations for glomus tumors in a visceral standpoint. They typically are small and often associated with long history of pain, especially the cutaneous and the ones in the nail bed, and long history of pain, particularly with exposure to cold or minor tactile stimulation. But the deep-seated or visceral glomus tumors present as non-specific masses, just like any other visceral mass. And grossly, they form circumscribed ovoid or round nodules with a solid or cystic and often hemorrhagic surface. And morphologically, this is a very typical picture of a glomus tumor, where you see these vessels lined or encuffed by these glomus cells. Rarely they can show sheets, as seen here, and as seen in our case, where it becomes a little difficult in this morphology. Sometimes they can show these large cavernous spaces, in which case the term glomangioma is used. In certain instances, they can show sheets of cells with this vessels showing the staghorn-like HPC-like vascular pattern. We use the term glomangiopericytoma in this case. And when do we call something malignant? There's been some evolution in this. What is the criteria for malignancy of glomus tumor? Earlier, if you look at the prior WHO book or the current one, which is the 2013 book, it says that glomus tumors, one of the criteria is size. Anything more than 2 centimeters in size and something with a deep location should be considered malignant. But in the upcoming WHO book, there is some change in what is the criteria for malignancy. Right now, the criteria is anything with marked nuclear atypia in any level of mitotic activity, or if you see an atypical mitotic figure, that should be called malignant glomus tumor. Usually in malignant glomus tumors, there is a component of pre-existing benign appearing glomus tumor that is present. And when a glomus tumor becomes malignant, it can be of two types. One, a more spindle cell leiomyosarcoma-like or a fibrosarcoma-like, or more like a primitive undifferentiated round cell tumor. So if you have a tumor that doesn't fulfill criteria, you can put it in the uncertain malignant potential category. Immunoprofile, again, very typically, characteristically strongly positive for smooth muscle actin, muscle specific actin. Desmin is almost always negative. And there is abundant pericellular production of type 4 collagen. So you can use stains for type 4 collagen and laminin as a marker in this case. CD34 expression is focal or absent. Recently, there have been some reports of BRAF mutated glomus tumors, which are BRAF IHC positive. but this is a very small subset of cases. What about synaptophysin, the diffuse synaptophysin that was seen in our case? Interestingly, it has been reported only in gastric glomus tumors. So, in this study from 2017, 5 of the 6 gastric glomus tumors expressed strong synaptophysin positivity, but none of the glomus tumors of other sites expressed any synaptophysin. However, the frequency of synaptophysin positivity, I mean, in this paper it says it's strong, it's very frequent, but in some other previous studies which look purely at gastric glomus tumors and the immunoprofiles, synaptophysin was reported at about 18% positivity. However, chromogranin was negative in all cases. So, we should expect that some cases will definitely stain for synaptophysin diffusely. So, I think that should be at the back of mind when we are looking at any of the cases. What about molecular findings? Not much was known until this paper from Memorial earlier in this decade, where we looked at a bunch of glomus tumors, about 33, and we found that by RNA-seq and by FISH validation found a novel microRNA 143 notch related gene fusions, and this was found both in benign and malignant glomus tumors, and the notch gene fusions occurred either in notch 2 or notch 3 or notch 1 genes. So, why notch genes? Because notch genes are extremely important for angiogenesis and in the pericytes for the proliferation of blood vessels. So, that comes under the strong promoter of microRNA 143, and that is how the notch is upregulated in these tumors. Very recently, as I mentioned, a very small subset of sporadic glomus tumors have shown BRAF mutations, and they have also been associated with malignant histology. In a subsequent ongoing study, and we wanted to find out what the true frequency of notch gene rearrangement is, we looked at a bunch of 93 glomus tumors, both benign and malignant, which we had FISH done for notch genes, and some cases even had RNA-seq analysis. We submitted the results to the USAP last month. So, we had 93 cases in total where we had FISH for notch genes, and we found that about 50 cases had notch rearrangement, which is about 54%, and 43 with no rearrangements. Of the glomus tumors with no rearrangements, a vast majority were benign, with some being uncertain malignant potential and only 1 or 2 being malignant. And again, a slight female preponderance, but about half of these tumors with no rearrangements were in the subungual or the finger location. In the notch rearranged cases, 2/3 were benign and 16 were malignant. In the benign cases, most of them occurred in the deep soft tissue or soft tissues of the extremities, had a overwhelmingly male in males, whereas in the malignant glomus tumors that we had, which were notch rearranged, about 2/3 were seen in the GI and the lung. And among the GI tumors, almost all of them occurred in the esophageal gastric location, with one case in the small bowel. Here are some examples of again more GI located glomus tumors. This is the one in the small bowel, and again we see a very cellular tumor with some areas showing distinctly round cell morphology with sheets and other areas showing more spindle cells. Here's an example of a diffusely positive collagen type 4, which is very helpful from a diagnostic standpoint. Another case in the GE junction, and this case showed very similar collagen deposition, very similar to what was seen in our case, had these areas of almost undifferentiated round cell morphology and some areas that even showed some clearing. This case from a gastric location in a 31-year-old had this very characteristic morphology of 2 different types of nodules. The nodule on the upper left showing this very benign glomus tumor appearing morphology, and the nodule below showing this high grade sarcomatoid morphology, clearly showing the sarcomatoid differentiation in a glomus tumor. This was another esophageal tumor. You can see the tumor bulging into the esophagus and ulcerating the mucosa, and showing this diffuse clear cell change in the tumor and this very sarcomatoid appearance in some of the areas of the tumor. What did we, and this was another case which we saw this last year. This is a lung met from a gastric primary which was diagnosed in 2013. And in 2013, the gastric primary was diagnosed as a malignant mesenchymal tumor. We could not really type it. But when we saw this lung met, we did Archer on this and showed a microRNA 143 Notch2 gene fusion, indicating that this was a met from a gastric glomus tumor. So what did we find from a molecular standpoint? We found that among the Notch gene rearranged cases, benign cases, again, a vast majority of them were Notch2 rearranged, with a few minor cases of Notch3 and Notch1. And the most common partner was microRNA 143 for the Notch2. Very similar findings in the malignant category, where a similar percentage were Notch2 rearranged, with 2 cases showing Notch1 gene rearrangement. And again, the most common partner was microRNA 143. Well, what is the prognosis of glomus tumors? Typical glomus tumors and all the glomangiomas, glomangiopericytomas are all been considered benign. The malignant glomus tumors are aggressive and they can metastasize, and from literature, the death from disease is up to 40% in some of the papers. And some large visceral glomus tumors without other atypical features, or in other words, uncertain malignant potential, have behaved aggressively. So that is the prognosis. What about gastric glomus tumors per se? In the AFIP study from Miatnan and others, of the 32 patients, 17 patients had no evidence of disease. So a vast number of gastric glomus tumors are also benign. And there was only one patient who died of liver metastasis in their study series. So summarizing, I've presented a case of a gastric malignant glomus tumor with microRNA 143 Notch2 gene fusion. Glomus tumors, apart from their typical locations in subungual and distal extremities, can also be seen in the GI tract and other viscera, particularly the gastric location. And gastric glomus tumors do show expression of synaptophysin in a lot of cases, so a pitfall that should be in the back of the mind. And nuclear atypia and mitotic activity are key features that are indicative of malignancy. Notch gene rearrangements are seen in about slightly more than half of glomus tumors, and most of the malignant glomus tumors appear to be rearranged, Notch gene rearranged. And interestingly, most of the subungual glomus tumors, the most typical location for glomus tumors, the subungual glomus tumors do not seem to have a Notch gene abnormality. So maybe the genetic abnormalities of those tumors are different. And FISH or Archer is a very useful tool to identify the Notch gene fusions. So I'll just stop at that. I have to thank Christina Antonescu and her lab for the study.